So we are on week 9. Week 9 is our last real lecture before we go into our HESI. As I said, I'm going to start sending you out some HESI prep information because it's the same information to prep for HESI as it is to prep for your exam 3 too. So, you're getting a double there. Know that this week we are going to be doing a couple different chapters. This is the chapters that we do neuromuscular and musculoskeletal problems. Let's see what else is new here. You have a discussion question and then you have a dosage calc worksheet. Questions about the dosage calc worksheet. Students want to know if they could take a picture and send it in page by page. It's no problem. If you want to color on the handout, that's fine. You want to use a piece of paper and pencil, that's fine. As long as you give me your work in some fashion, no problem. And it is multiple uploads. So if you want to do paper, whatever works for you, whatever you understand technology, I can figure it out. All right. So that is the calculation worksheet. There's some crazy sort of calculations there. It's just to open your mind to different ways that you can do different calculations, etc. All right. Remember, the Calculate with Confidence workbook has all your answers there. Go back and figure out how they're doing those questions. It is a big reminder, it's a big refresh before you go into the HESI. And then you're going to say, so what sort of math is on the HESI, right? It's not going to be that complicated, believe it or not. There are a lot of DHQ or IV fluids rate. There's no big stuff on the HESI in pediatrics, okay? In pediatrics. So when we're done, yes, we're going to do our cahoots.
Will we
So
have to, I'm sorry, will we
good.
have to show our work for the drug worksheet?
Yes, show me the work how you got it. Yes. I mean, anybody can copy all the answers, right? But if at least you have to write down, what you're doing, at least you're seeing how these things are done.
Okay, I
'Cause
just
I,
asked
I know
because
I know some students will do them all and do them the
Mhm.
right way, and there's some that'll copy and paste. I get it. As long as you know how to do those questions. That's my concern with it.
Well, I just asked because like I've never been able to use the equation that they give us, like the dilate this over that, and
Oh
so
yeah, yeah, the
I've always
ratio proportion analysis. I don't understand that either, Jerry.
yeah,
Me and you are together.
I've always had to figure out my own way how I can arrive at the answer, and it's a lot different than everyone else's. Like, even
So,
with
Jerry, did you look at my way I do it? I'm sure you're doing it the same. Have you
no,
seen
I
my
haven't looked at
dosage calculation video?
no.
Okay, do you get any math questions wrong?
Have I gotten them?
Yeah, on the exams, do you get your math questions correct? So you're pretty
Yeah,
good?
I get them all correct. Yeah.
Okay, good. Because I don't do ratio proportion analysis.
Hmm.
As you said, that over the this and add this and subtract this, and for me, it's just a plant for more errors. There's more space to cross things off that could be. So I just show you how to pull out the right part, and almost everything is a desire over a have times quantity um, question, and we can figure them out there. I'd like to see how you do it, Jerry. I can probably expand. No, seriously, expand on the way I do it. Maybe there's a different something there. So if you
Okay.
can, make a message to me. I'd love to see what you do.
Okay.
Absolutely. It can help me help more students too. So appreciate it. All right,
Mhm.
let's go ahead. I learn from students all the time. Actually, I was at my other grandson's graduation from preschool, and I met a student from Fortis I hadn't seen in about 5 years. And it was like a hug at meeting. It's been a while. And she's doing really good. And, of course, she remembers, are you still there at Fortis? Yes, I am. So anyway, here we go. Musculoskeletal articular dysfunction. This is those sprains and breaks and all of those sort of good stuff. Now, let's talk about musculoskeletal and let's talk about children. Well, we know that children, as much as we don't think, they can be in a prolonged state of not being able to move, being so sick, and it could be any reason why. You could be born with it, something that's degenerative. One of them that I mentioned with degenerative is always osteogenesis imperfecta, brittle bone disease. That means you are constantly breaking bones, and bones are being, they're not formed and they're getting crooked and et cetera, et cetera. And of course, we know infections, trauma, anything is going to put you down for a while, or any therapy that needs you to be put down so that you can't move. So, what is our concerns as a nurse? Well, we don't want the muscles to get atrophied. We want to make sure that the bones are, especially children that are still growing, they still need the nutrition for, good bones and bones keeping strong. The cardiovascular, lungs and heart, this is talking about your pulmonary embolus, your blood clots in your legs, and we don't want any of this to occur. And what you do for adults is what we do for children. The greatest thing about turning and positioning a 1-year-old is they weigh 20 pounds. They don't weigh 200 pounds. And you can really turn and position them and make them as just clean and neat as you want. And that I used to be OCD about it. Nobody would make a bed with me because I like it. Pull the corners, you could bounce a quarter on it, they used to say with me. But the kids were turned and there was no creases. It's because of these things, because they were laid down, and I don't want any problems with the cubituses, et cetera, et cetera. Now get an older kid. Get an older kid who has to be in a hospital for a long time. Number one, they just don't feel good about themselves. I'm no good. I can't do this. I can't see my friend. I missed that basketball game, the dance, so this, whatever. This is like such a frustrating environment for them. They're very helpless, especially if they're also bedridden, right? They can't get up, they can't move. What does that happen to that child? Well, of course, they're going to become depressed. They're going to be angry because they're just, why am I like this? I don't want this. They will become aggressive. And then, of course, some of them will regress. They'll start sucking their fingers, start becoming incontinent, and just doing that regression because they just can't handle what's going on. So remember, any kid who's in a hospital a long time, especially in a closed up room by themselves, I used to always go in there and bring my computer and sit with them and do my charting, whatever, and be with them and talk with them and watch TV. And that's all I need sometimes. What about the family on that child? You have a family now who has a brother, a sister, a son, a daughter, an aunt, an uncle, a grandmother, grandfather worrying about their children, right? It's really disrupts everything. So extended periods of immobilization and hospitalization. Remember, there is coping that needs to be done on all levels. The family, the child, parents really need support. What I found at the hospital I worked at, this pediatric facility, every single floor had a specialty, and every floor had a parent group. They had a cardiac parent group, a neuro parent group, a chemo cancer group, and they could sit and talk about the way they feel. Can you imagine having another person who understands that has a child almost in the same condition, and they can share ideas, or maybe there's some sort of resources this one found that this one didn't know. It's a great thing, those parental groups. Usually they met every month, is the ones that I knew. Okay, let's go into children, and now they're up and out and they're moving and they're playing. So we know a lot of soft tissue injuries could be muscles, ligaments, tendons, anything. And we know kids are up and out and running. Now, the biggest thing is probably the big bruises, contusions, right? Now, be careful. Sometimes we get contusions, let's say on the arm, a finger, a leg, a toe, and it's causing a lot of swelling. Remember to always check neurovascular signs. Just because it's a bruise doesn't mean it's not bruised inside and occluding blood vessels. So always in contusions, bruising, breaks, fractures, everything. Big concept is checking neurovascular signs distally on the toes or on the fingers. Okay. We know if we see the ecchymosis and whatnot, we only see the top. It could be all the way underneath. And especially things like crush injuries, which that's what children do. Dislocations. Probably the biggest dislocation that we see is that nursemaid elbow, it's called, right? The little 2 to 3 year old child, you like to swing around with their arms, and all of a sudden their elbow, the joints pop and the arm becomes straight and they can't bend it. So we have to go in and we just twist it and it pops back in because the ligaments are so stretchy and pliable, okay? The other person we need to be concerned about with dislocation is our Downs children. Have you ever been around a Downs child? They can take both legs and put them behind their head. They are so flexible. The problem with it, though, is when they take that ball and socket of that hip joint and that femur, put it over the head, it could pop out. Now you've got a dislocated femur, which again, you've concerned about neurovasculars, blood supply, et cetera, et cetera. So what is our goal in dislocation? Well, before we can get it fixed, is always checking neurovascular signs again. And then after it's fixed, okay, it's also checking them, making sure that we have it in good alignment. And if we have to place any sort of casting, checking for circulation. You're going to see this all along. Now, a sprain. I've had so many sprains in my life, I can't count how many. Never had a fractured ankle or anything, but playing sports, I used to always go up, spike a ball, soccer, basketball, baseball, didn't matter. I would always kill my ankle once or twice every year. It's probably more painful than it would be a fracture. Now, years ago, they didn't immobilize bad sprains. Today they do. They feel like immobilizing them, elevating them, that rice, that rest, the ice contain, that elevate is what we need to do. And then in sprains today, they are putting an immobilization or even casts on. They feel that they heal better from that immobilization. Now, what's a strain? Well, a strain is like an Olympic athlete doing one thing over and over again to strengthen one set of muscle groups. And because they've overdone them so much, they tend to get these quote strains because of overworking. They're little microscopic tears that happen. So, as I said, you get a sprain, you go up, you spike that volleyball, you come down, and you feel your whole ankle rip. And you can hear it, and you're like, oh, and you can feel the swelling start. So, what do? Immediately stop, ice it, compress it with like an ace bandage, elevate it. And that's what we do. I got to the point where I knew if I knew I had sprained my ankle, I would be on the floor and I put my leg up immediately. And it did help a little bit with the swelling, but we know with sprains, it's all, discolored and ecchymotic and swollen and extremely painful. Again, as a nurse, we're going to be checking our neurovascular signs, okay? And helping with the pain. Now, fractures. In children, the most common are the forearms. And why? When you fall, what do? You put your arms out. So bilateral forearm fractures are not uncommon at all on older children. Now, what about younger children getting fractures, infants? What have I told you about infants and their bones? Remember, they're soft, they're malleable. It takes a lot of force to fracture an infant's bones. I had one 3-month-old infant that came in with a fractured skull. And when we did the x-ray, we found out the child had a fractured humerus, fractured ribs, fractured femur. It was a child abuse case. And it was just that fractured head that didn't make sense on a 3-month-old. And the mother brought the child in. It wasn't the mother that did all this stuff. But she was so concerned. But when I saw this head, my goal in any sort of concern about child abuse, I'm going to protect that child. The child is my concern, and we did protect that child, and we did get him to safety. And the person who did that to him is where he needed to be. So know that forearms are the most, because children will put their arms down. Now, there's different sort of fractures. Mostly children have these simple or closed fractures. You fall down off the monkey bars and you fracture your elbow, your arm, wherever. And that's, you don't see anything bulging through. There's swelling and pain. Okay. There are times where the fracture is so bad that the bone comes out through the skin. Well, once the bone comes out, hits the skin, it's infected, right? The skin, the air has all sorts of germs in it. And our biggest concern is osteomyelitis or osteobone myelitis infection of the bone. So we don't want to do that. It takes a lot to get osteomyelitis to cure it. So if we have a child who has an open fracture of the bone, our priority on that child is to get IV antibiotics in them because now we're treating a possibility of bad things. Now, you're going to say they have pain. Well, just like sickle cell, we're going to give fluids first. We're treating the reason, okay, or treating it to try to help them feel better. Same thing with this one. We're going to give IV antibiotics. Yes, pain medicine is in the other hand, but we need to get IV antibiotics to make sure we keep those bones good and not getting infected. There are some where you can be in a car accident or something and you've had your chest hit and you have rib fractures. Rib bones can go into lungs, causing punctures of lungs, could puncture your liver, your spleen, all sorts of things. That's called a complicated. Comminuted is where little pieces are everywhere. And then the avulsion is almost like a sprain, but the tendon and ligament pulls away from the bone. So again, it's a worse sort of sprain, but it's called an avulsion. It is a fracture. Now, every child, every person has something called a growth plate. If you look at those bones on the bottom, you're going to see it's at the bottom, or like where it connects to the elbow, or it connects to the elbow here and here and here. These are all growth plates. Now, children do fall down. Children do get fractures in the growth plate. Now, this is how children grow inches. So if it's a crooked, after we fix it, that arm, that leg is going to be crooked, correct? If it's hitting the growth plate. So growth plate injuries, they will have surgery. Open reduction, internal fixation to make sure it's straight so that there's no crooked and that the bone is going to grow at the same as the other arm, the other leg. Funny thing is at that graduation I went to the other day, there was a little boy who just came in who had a growth plate fracture and had this little cast on and had this little sling on, and the sling at his wrist pointing down. And he just had surgery that day. So I showed the parents how to pull up that little, the elbow restraint and to make it fit a little bit better. So it was interesting, a growth plate fracture. Now, children. Most children only need a cast on for about 4 weeks. Me or you are going to need it 3 to 4 months because it has to do with bone healing. Look at neonate period. Now, what is a neonatal period? That's ages 0 to 28 days. That's the first month of life. You get a broken bone or anything like fractured clavicles at birth, right? Could be. Um, hip dislocations. We're going to talk about that. But look how quickly it heals. 2 to 3 weeks is all it needs. What if they have club feet? We start putting cast ons and we're molding them quick because the first 4 weeks of life, they heal so quickly. After that, it's about 4 weeks kids will have on their cast. And as I said, I'm probably going to be 6 months by, being older and all the things going on. But again, knowing that bones heal this quickly, a neonate, we are going to rush to get that cast on, to get whatever they need, because we know the quicker we do it, the quicker it heals, right? So we get a child in complaining, fell off monkey bars, you see a swollen wrist. What are we going to do? Well, number one, as a nurse, we're going to be checking neurovascular signs, right? That's our biggest priority here. Pain, yes, we can give them something for pain if they need it, but we need to diagnose it. Let's get them over to x-ray. I usually would use x-ray as the place that I would talk to the child alone. So tell me, were you high up on the monkey bars when you fell off? Tell me what happened. And they'll tell me a story. Is it the same as what the parents tell me? And you're wondering why I do that. Well, I've seen such cases of abuse that I'm just there to protect the children. And if they tell me the same story, it's great. I will still treat all the children, all the parents the same, no matter my suspicions. But my goal is to give the best care I can to that child and keep them safe. Okay. So once we get that little bone, we can see it's fractured. I will always show it to the child. I was very lucky to live in a hospital that had a computer screen in every single room. And I'd pull up that x-ray so the kid could see where the fracture was so they could understand why the cast was on, why they had to hold it up, why they couldn't go swimming. And it just gives them that point of reference. Oh, I know it's fractured, and it's fractured right there. And I think that gives them empowerment, doesn't it? One of the things with feet, um, if they are not putting weight on it, you can almost guarantee it's fractured. A child who has a sprained ankle or whatnot, you'll see them limp a little bit, not on a break. They will not put any weight down. Now, I put the really bizarre, type of circulation occlusion and a death of an arm. Okay. That is like the extent of way far, but that can happen. So we take and we put a cast on. These are the 6 Ps, and you need to know what these are. Very important. You're going to assess for this. Pain. Where is it painful? Is it here? Is it here? Is it here? Where is it on the arm or the leg? What's the color? Is the tips of the fingertips or toes, are they pale or are they pink? If you can feel a pulse, can you feel it or not? Is it numb? Paresthesia. Like if it's the wrist, are my fingertips, I can't feel them, or I can't move them, or is it pressure swelling up? This is going to help keep a cast on, keep it safe, because if it swells and we're going paler, pulselessness, we're going into compartmental syndrome, and we could go and we could cause an arm, a finger, something to die, right? If we don't get that blood flow down there. Now, casting for children, most pediatric hospitals might have all of the colored casts. I know our adult facilities down here do not, but I know where I worked, we used to put all colors, the red and the black from Miami Heat, the orange and aqua for the Miami Dolphins. We would put orange on for Halloween, orange and black. We put green and red for Christmas. I mean, all the different colors, any color combination. And because we did that, the kid's distracted. He's not just getting a cast, he's getting this color thing made. And him and the orthopedic tech have decided how that color is going to be on. Like this girl, she's got watermelon colors, as I call it, but look at her doll too. We put it on the doll. And again, what did that do? Took away all of that distraction, right? Put it somewhere else because setting a bone is a little uncomfortable. So that helps. Um, Taking care of the cast at home, teaching the child, teaching the parents. I think the biggest thing is water. And the biggest thing I've seen is kids with a fracture on the arm, with a cast on, go home, put their bathing suits on, and jump in the pool. And the parents have to turn around and come back in. Like the kid just went home and jumped in the pool and they have to get another cast. I saw one kid do it 2 times, go home twice and go into the pool. So again, that puts fungus and all sorts of things that can't get wet. Again, nothing in there, hair dryer, nice little cool breeze is the best thing. No sticking things in there because it can become a big, big infection. Now, sometimes we do traction for fractures. I think the biggest one we use traction for is fractured femurs. And I've actually put this on in the emergency room on a young boy who did have a fractured femur. So why did we do it in the emergency room? Well, let's think about what a fractured femur does. So you've got a bone and it fractures. And you've got these big quadriceps, and these two cracked, sharp edge bones start pulling and pushing into nerves and the muscles. And the muscle spasms are extremely painful. So you put a traction on, and it straightens out the bone. And then the muscles stop with all of those spasmings. And it gives the surgeon a chance in order to do surgery. Years ago, we used to put stymon pins in these, and they'd be in a hospital for a month, no more. We put them to surgery, and we will put in a spike right down the middle of it, and they will close up that bone and keep it rigid. Okay. So again, what is the traction for? It's to relieve that fatigue in the muscles and the spasm. Is to get the bones together. Is to keep it from not moving so we can start this healing process. It prevents deformity. It helps immobilize it. And the big thing is that muscle spasming, stopping it. Traction, as I said, fractured femur is the big one we use. We've used it, and I've used it, the one on the left, when we put in the tongs, fractured spines, we can hold the spine straight by putting those things in. The one on the right, there's something called a Chiari syndrome, where it's the first two vertebrae, the C1 and C2, the atlas and the axis. The hole with the fluid comes in and out. There's something wrong with it. And they have to do surgery on the spine. And post-op, they put them in this halo to hold it until that spinal column can heal up. So those are all tractions. What is your job with all of these tractions, right? Here's some more. So this is telling you upper extremities are very uncommon. We don't use them much. It's mostly the lower extremities. You need to know Buck's traction is the fractured femurs one. Again, any traction, if there's weights, they have to be hanging freely. You never touch them. And you're going to document in your nurse's notes how much weight is on it and that it's hanging freely. That means you have a constant pull, and that bone is going to maintain, where the approximation of their edges, what you really want them to. So that is Buck's. Now, Russell's is Buck's traction, but it just has an extra piece on it. It's used the same way I've used Buck's a lot more than I've ever used Russell's. The other one that we use on young toddlers that have hip dysplasia, and the normal way of putting it back doesn't work, we do something called Bryant's traction. Now, with hip dislocation, the hip is not in the socket, it's up here somewhere. So we put them on their back, their hips are slightly off, their legs are at a right angle, and it sort of pushes it back into the socket. Okay, again, it's weights hanging freely, and those are the ones you need to know. Another thing we can use is something called external fixation device. If you've ever had a child, I've seen my doctor at 50 years old decided that his legs were too short and whatever. He did bilateral lower leg distraction, this external fixation device, and he gained 2 inches. But these are mostly done on kids that usually have one leg, one arm. I've seen it that's shorter than the other. And what it does, it breaks the bone, then it puts these pins in it, secures it in that area. And the bone creates its own little seal, and it ends up that it will grow inches, whatever it needs to be. Our job as nurses is just to make sure that the pin sites are clean and you do pin site as told. Sometimes even say turn the pin, 30 degrees or whatever, or turn it once every day. But again, it's just to protect it from infection. Now, sometimes children are born without an extremity. Sometimes they're born, and I had a friend whose daughter was missing the fibula on her lower leg. So you have a fibula and a tibia, right? Now, when you don't have one bone, you can't walk. And there's no way to put another bone in there to substitute for that bone that's not there. So this girl did have to have a below the knee amputation. Now, I met this little girl at age 4, I think she was. That little girl got around better than my children. She met my children, and I had a 2-story townhouse. This girl was running up and down stairs, taking her prosthesis, and was chasing my children around the house. And I heard so much giggling and laughing. This girl was she didn't care that she didn't have a leg. She was having some fun, beating my kids up with it. So again, it's the approach, right? Now, Again, with amputations, and if we have to do one, it's just like an adult with a surgical amputation. There's going to be phantom pain. Remember, with using prosthesis, making sure the stump is good, making sure that the prosthesis fixed correctly, and getting these kids up and moving and getting them active. And that's the goal. Sports, kids, they love competition. Know that they are going to go out there and push themselves as best as they can. One of the things is those overload injuries where they just keep going, 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 and they don't stop. Um, and that can cause those sprains and strains, et cetera, et cetera. Same thing, strains, the overuse syndromes. They're training more and more. And again, it's that same thing used over and over again, and it causes these little stress fractures. I've mentioned the hip dysplasia, right? Hip dysplasia in children. Well, children are born sometimes, and the hip can be anywhere from here or to here. That means it's not in the bone socket. So our goal is to get it back in there. Now, how would we know that child had hip dysplasia at birth? Well, these children, what's the first thing the pediatrician does when he meets your little child, your little baby? He's going to take those little knees and put them up the chest, pull them down, and pull them out. He's listening for that click, right? He's listening to see something's going on. Turn them over, the baby on the belly, and look at the buttocks, the gluteal folds. They're going to be different. And one leg is going to be shorter than the other. Okay. And girls more than boys. So you'll hear that, shortened limb. You're going to see the abduction of the hip. There's, gluteal folds are going to be one's up, one's down because that's where the hip is. And then positive Ortolani, positive Barlow tests. What do we do when we see that the hip is not in a joint? Well, in order to walk, they need to have it there. So again, this is a neonate. We find this at birth. We're going to put on what we call a Pavlik harness. Pavlik harness abducts the hip and pushes that hip joint socket back into the joint. Okay. And this is just a device that straps on. It's on 23 hours a day. You only take it off to bathe the child. The thing with it is it's got these straps on it, and it tends and it can cause a lot of friction. It can cause sores. Make sure that they have a cotton t-shirt underneath it to prevent these things, and to make sure we inspect underneath this harness when we have it off that 1 hour every 23 hours, right? And we can take it off. Older kids that can't get this hip back into shape. And then we've done the Bryant traction, trying to get that hip back into the socket. And some kids that still can't get it in, at this point, those tendons are so tight, they can't stretch enough to get it in there. And they do something called a tendinotomy, which means they make holes and they stretch it and they put the hip back into where it needs to be. And then, of course, physical therapy and heal it. Now, the other thing I said about casting is club feet and babies. Now, there's different sorts of club feet. You do not have to know all the names. Just know that a foot can be turned any way and still be considered club feet. Don't matter which way it goes. What do we do for club feet? Well, it's not a surgical condition. Remember, their bones are malleable and flexible, right? So we're going to do something called a Ponseti method here. And what we do, it's called a serial casting. And we will put on every week, because remember, they heal so quickly. Every week, a new cast becomes on. We're not going to leave it on for a month because we could have healed the whole thing by then, right? So every week we put a new one on. Now, because we had these club feet at birth, these children need follow up. with a podiatrist, an orthopedic guy, to follow those feet as they grow older. They may need some sort of special shoes, et cetera, et cetera. Now, osteogenesis imperfecta, I mentioned it briefly about degenerative disease, and this is brittle bones. Why? We don't know. It's inherited. It's no cure. It's just, as nurses, you have to be so careful touching these children. I used to have them on blankets, and I get another nurse with me, pull one baby blanket from one side and one on the other to lift them up, to put them in a lap, to feed them or whatever, because you're afraid of your fingers crashing, ribs or anything. I mean, they're very brittle. I mean, the care is supportive. We might be giving, different meds, but it doesn't really do anything much. Our goal is, if we have breaks on this child, our goal is to try to keep them in a position where they still can be mobile. I know in the hospital where I worked, there were children with osteogenesis imperfecta, and they had motorized wheelchairs. And I know when I worked the day shift, I would all of a sudden hear a kid beep, beep, beep on the way to the cafeteria, and they were one of these osteogenesis imperfecta in a wheelchair. They're up, they're mobile, and they're feeling, quote, as normal as they can be, right? Late calf birth. This is a hip problem where it's an aseptic necrosis. What's that? Means no infection and the femoral head is dying. Necrosis. What happens? Well, all of a sudden this child's going to start limping. And they're going to say, what's going on here? And it's going to, sometimes it's usually just one hip. It can be both, but usually it's one hip and it's this limp. And it's stiff, and there's no reason. There's no bruising. There was no fall. There's nothing. Again, it's once they're sitting for a while or arising in the morning, they're the stiffest, okay? They'll do an x-ray, and they're going to see like a fuzzy head of the femoral bone. And it's telling you something's going on there. Aseptic. So our goal is to protect the head of the femur. So it is bed rest, no weight bearing. This child is going to be put on Buck's traction. It's going to hold that joint out, and it's going to let that hip and that head of that femur rest, okay? And NSAIDs are what we do. I mean, this is a child who's more apt to get hip problems and needing repairs, in the future, hip replacements, etc. But this is no infection, so it's home rest, NSAIDs, maybe a little bit of some traction, and of course, good nutrition for this child, good protein when we're talking about anything with bones. Now, I'm going to go over three different spine things. Kyphosis is basically that hunchback. All right, it's the upper back. Usually it's postural. These are some older people you'll see, and they're bent over. It could be by the way they worked or whatever. Lordosis, different one. It's the lumbar spine. It curves in, so you sort of walk sort of backwards. Lordosis is very common in a condition as we go further up. I'm going to tell you, it's Duchenne muscular dystrophy, but we'll go into that next. Lordosis tends to have heavier children because of the way that they walk. So again, they're going to have these big bellies, and they're going to be stretching back to walk. Now, the most actually commonly tested of all of them is scoliosis. Now, scoliosis is an S-shaped curvature of the spine. So you're going to see it curved. Now, if you look at that picture, do you see how that right shoulder is elevated and the left one's down? That's usually what we see, especially when they bend over, you can see those things. So this usually occurs during that pre-adolescent growth spurt. Remember, they grow about 20 or 25% of their height and weight during that time? Well, their spines tend to be more S-shaped during that time. It's where it becomes a lot more noticeable, okay? We don't know why it happens, it just does. So how do we treat it? Well, the spine reacts to the muscle groups in the back. So good physical therapy, right? Strengthening those muscles up. Also, let's keep that spine from getting crooked. Let's put on a brace. Now, that brace, again, 23 hours a day, only take it off for bathing, and wear a cotton shirt underneath, protecting the skin. Same sort of thing. Now, you can do the bracing and the physical therapy up to a curvature of about 40 degrees. After that, that curve is so severe that just physical therapy bracing is not going to work. And they have to do surgery. And what they literally do is called Harrington or Lukey rods. Sometimes they do spinal fusions today, it all depends. But if they do this Harrington rod, they take a metal rod and put it on both sides of the spinal column and attach it and try to straighten it out as best they can. This is the child that's log rolled postoperatively. We've heard of what log rolling is. This one, absolutely. We need to protect that brace until it gets good and adhered to the bones. We've mentioned osteomyelitis. We know that's an open bone in the outside for some reason. Sometimes it could be as simple as they were outside and their big toe is turned red and it's painful. It could be osteomyelitis. The symptoms, pain, redness, and it could be to the point of fevers because it does come systemic. Because it is a staph infection, it will go systemic. So do a x-ray, we could see there's probably infection. Do a CBC, elevated white count. All right, so now we know what it is. If we can do a biopsy or aspirate, we will. But again, what is our treatment? IV antibiotics. This is a severe bone infection, and it's going to take a long time, 3 to 4 weeks, up to several months. Now, this is a staph infection. What antibiotics are going to be used in this IV antibiotics at home? Probably with a PICC line, right? These are your aminoglycosides. This is your vancomycin, gentamicin, amikacin, all your sins. Remember pharmacology in your sins. Remember the biggest concern, peak, troughs, worrying about kidney levels, hearing, toxicity, right? These are things that will be monitored as we give these medications for these extended periods of time, and to make sure that they're following up, getting that follow up peak or trough level, making sure their kidney values are good, et cetera, et cetera. Okay. And again, as I said, bones, nutrition, very important. How do you heal? Good protein, right? Very important. Now, Ewing sarcoma is a bone cancer, and it could be anywhere. A femur, a tibia, ulnar, a humerus. It could be in a jaw, it could be on a scapula. Um, we try to take the bone out if we can, but not all those bones can be. So it's again radiation, chemo, and surgical resection. Now, JIA is also known as juvenile rheumatoid arthritis, but the new name is JIA. And it's basically the body attacking its own joints. This is again is that child who wakes up and is stiff in the morning, maybe the hips, maybe a knee, maybe an elbow, maybe all of them. Extremely hard to diagnose. I haven't shared, I do have rheumatoid arthritis. It took me 8 years to be diagnosed until they finally figured out what I had, and to give me some treatment that gave me relief. So again, kids, they have this stiffness and they start complaining. So again, that morning stiffness, you'll see. Difficulty walking because of that stiffness in the muscles and the joint hurts. And of course, a limp. You're going to see obvious swelling, disfigurement. Could be in fingers, could be in wrists, elbows, could be anywhere. And then, this is something I didn't know about, uveitis. That's, your eye gets all reddened in there. This child needs yearly eye doctor checks. So, how do you diagnose juvenile idiopathic arthritis? Basically, it's the assessment. Yes, you can go ahead, you could do all the lab tests. Sometimes you'll see them positive, sometimes you see them negative. But again, continuing being of having the parent being the advocate for the child and keep going back and back until you get that diagnosis. Usually in JIA, you will see positive inflammatory factors. Your CEA, you're going to see the CRP, the C-reactive protein. You're going to see your sedimentation rate up. You're going to see positive ANAs, positive rheumatoid arthritis factors. And the things sometimes they're negative, sometimes they're positive. So again, hard to figure out. How do we treat it? Well, number one is keeping those joints mobile. That's always your number one. So that's preserving function and preventing deformities. I think swimming pools are the best thing for rheumatoid arthritis. It's that movement, keeping those muscles moving, or whatever that kid likes to do. They like to do aerobics. Oh, please put them in there. Sometimes these children, they just need NSAIDs for pain. They don't need anything that strong, just the anti-inflammatory. And then sometimes they'll put them on some sort of infusion, whether it be like Humira or just regular infusions. And when you're in a quote flare of JIA and it's swollen and these children are really hurting, we will be giving some sort of steroid, corticosteroids. Also, in conjunction, they will be given methotrexate. There is oral methotrexate, and there is, the one sub-Q like Humira, same type of thing. And again, it depends on the physician, the way they want to do it. But the corticosteroids are only a band-aid. It doesn't treat it. Sometimes they give steroids too long, and then of course you end up with Cushing syndrome, which I ended up in. So I'm very aware. So again, management, keep them active, keep them pain-free, heat or cold, whatever works. You put heat on one of my arthritis joints, I can't stand it. Put me in an ice bath and I feel relief. Again, every child's different, whatever they like. And again, telling them whatever exercise you like. And again, swimming is a great thing to do. Now, lupus is the body attacking itself, but not the joints like JIA. It's attacking all the organs from the skin, the brain, the heart, anywhere, liver, kidneys, anything. So a lot of times we see this in young girls and women about age 10, and we don't know why it happens, but I think that age 10 is like the beginning of puberty, right? Beginning of the feelings of it. So it could be hormone. We do know lupus responds to overexposure to sunlight. So these children, you have to really protect them. Now we can have the butterfly rash. They look different in all different children. This is the way one might look just red, one might be darkened, but it's a rash on the face, okay? You're going to see swollen lymph nodes. You're going to see that generalized weakness and joint pain. And the other thing, as we get going, is that forgetfulness. And one of the things, it can attack the brain, seizures, paralysis, or it could attack the lungs or heart, pleurisy or pericarditis, right? So again, what's our goal? There's no cure at all, JIA lupus. You just have to treat it. You need to, whatever it needs for you to lead the best life you can. So again, with lupus, I'd be monitoring myself in South Florida if I was here, the sunlight down here, making sure sunscreen is on, etc. Question. So Kristen is 10 years of age, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What is an epiphyseal plate? What's the other name? That's the growth plate. So what are we concerned about setting a child that has a fracture in the growth plate? We know bone growth can be affected, and you have crooked bones if we don't do an open reduction internal fixation. Okay? Make sense? All right, let's go into neuromuscular or muscular skeletal, and here's some more. Well, neuromuscular is the first thing you think of. You think of cerebral palsy. What is cerebral palsy? It's permanent disorder, and it has to do with movements and postures. They have extremely abnormal muscle tone and coordination, and it goes from mild to severe. You have some cerebral palsy children that can walk with maybe a little bit of shuffle, maybe just a cane, all the way to the point of being in a wheelchair. And you don't know what it is. Again, this is something that occurs for many different reasons. We don't know all. I do know one of the things that I've seen affected a lot is something that happens at birth, where there's a hypoxic or anoxic episode, or child was born extremely premature, extreme low birth weight. Remember, their brains are fragile. They have brain bleeds, endoventricular hemorrhages, and this can cause cerebral palsy, okay? Or there's some abnormality in there that we don't know about. So, evaluating these children. So, why are we doing assessments? A child with cerebral palsy is going to be cognitively delayed. That means we're not going to see the fine and motor skills are not going to be done the way a normal child that doesn't have cerebral palsy to be. Okay. So that's why we're doing those assessments, checking for many things, but this is one. Spastic cerebral palsy is that hypertonicity, poor posture, and difficulty maintaining balance. That's the child that I used to work with in clinicals. I mean, Jonathan, was my sweetheart. He was an 8-year-old boy, nonverbal cerebral palsy, alert as could be. He would see me across the room. His arms would come up and he would start spasming, that spastic and smiling to hear, waiting for me to hug him because he knew I was coming. And that's just part of that spasticity. So, gross motor, fine motor, all of the reflexes, all are going to be delayed in these children. So, safety, 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 very important for this child. Some of these children, especially if they're alert, give them a way to move around, whether it's a walker, whether it's a bicycle. You know, you see the kids with a bicycle and it has ankle braces on. I mean, get these kids up and moving. It just feels a sense of feel good, right? I can move by myself. Also, you think children with cerebral palsy, especially little Jonathan, you think because he's nonverbal that he's not alert. Well, he has a little iPad that was given to him by the March of Dimes or one of those. And he actually was being taught things like what are shapes, what are colors. Years ago, I used to work for Cerebral Palsy Center as a volunteer as a high school student. They didn't have teaching, speech therapy, occupational therapies, physical therapy. I went in to help them feed, get them out of bed, put them back to bed, turn position. There was no education. Today, we are educating them. And the thing is, once you get that goal, again, make a better goal. These children are capable of more things than we do realize. We just have to have the patience to educate them on their level. We know with all these muscles and rigidity and all spasms that the ankle foot braces so that they don't get that foot drop, right? From all that spasms. Sometimes there's orthopedic surgery that needs to be done so that we can, stop those spasms of those muscles or joints that you see, right? Um, what is botulism? Jonathan got some botulism. It helped. And remember, most of the children with cerebral palsy also have epilepsy. Remember, with epilepsy, there are drugs like phenytoin, Dilantin, which can cause gingival hyperplasia. So dental health, very important. And of course, therapy. Keep them moving. Keep those muscles stretched. Now, Prognosis depends on how severe they are. Most children with cerebral palsy can get up and get around and be ambulatory. There are those that can't. Again, trying to give them, like Jonathan had his little wheelchair. As he gets older, probably get a motorized one because he was alert enough for it. These children are usually smaller. That's why their growth is affected. Again, many of them can't even eat properly. A lot of them are with a gastrostomy tube. Jonathan was, and he didn't eat anything by mouth because he would choke on it, couldn't tolerate it. His muscle coordination was poor. So, how do we treat cerebral palsy? Well, it's that exercise. That's number one, giving them the nutrition and medication as they need. Safety, safety, safety. And don't forget, these children do need some sort of recreational activities. I mean, Jonathan used to love it when they had this big screen TV and they used to turn on these music songs and he used to clap his hands with them. Now, it wasn't on beat, it was totally uncoordinated, but he had a smile on his face. So we knew that that did help him. And of course, physical speech, occupational therapy. And don't forget the parents. You know, they're dealing with a child who also is going to go home with them. Now, have you ever heard of a neurotube deficit? Does anybody remember folic acid in pharmacology? They said folic acid you have to give a month before you get pregnant to decrease the chances of neurotube deficit. Well, this is what a neurotube deficit is. Call it a spina bifida. I call it a myelomeningocele. There are all different levels of it, but we will call this a myelomeningocele. It's basically your meninges and spinal column are pulled up from the bottom and ripped out, and that's the meningeal sac that you see sticking out of the lower back on that infant. What do you think the care of that child is? Well, isn't that a worry about infection having the insides of the body on the outside, especially a meninges, a spinal cord? Yes, we are going to cover that with a sterile dressing. We're going to be giving prophylactic antibiotics. And the other thing with this is because it ripped nerves, pulling that up out, that spinal column, it pulled nerves with it, there's going to be no feeling or very decreased feeling in the lower extremities. So we have to worry about bowel and bladder here. Okay. Decreased sensation, decreased mobility there. As I said, neurotubes, it's from that folic acid, or it could be mom with diabetes that can cause it. Again, our goal here is when these babies are born, and even though we don't use latex anywhere in any hospital, almost every hospital today, we do put up latex allergy. These children, many of them will end up with decreased sensation for urination and require straight catheterizations every 4 to 6 hours. So having latex, it could create a really, really bad allergy. So we're going to always make sure there's no latex around this child. The one thing you have to remember is balloons. And I'm a latex allergy kid, and balloons and that in the air, I could taste it on my lips. So this child you have to be careful with. Again, as I said, not only urine problems, worry about the bowel control. Now, these children are going to have decreased sensation in their low extremities. Many of them are not going to walk, but they are alert. Okay. They're alert and oriented. I had a little boy, Manuel Louis. He was born and his myelomeningocele looked about as big as this picture. And I was in a room, all the other nurses were getting a report or something. And there was this mother standing next to this child, and it was not my infant, my baby, but the mother was there and I could see her crying. And I went over and I said, "What's the matter, mom?" She goes, "I don't know, my baby. Look what's going on. I don't know if he's going to make it." So I just took the time with the mother and I said, "Look at your baby. And what's his name?" And I got his name, Manuel Louis. And I put a sign up for her and made a little pretty little hearts and stuff on it for her. And then I said, "Look how beautiful he is. Oh, he's got big feet." I says, "Mom, you need to hold your baby. Sit down." And what I did, I wrapped this child up, put it in the mother's arms, and let her know that, yes, your infant's going to have struggles in his life, but I knew that she'd be a great mother and she would take good care of him. Now, 14 years later, I'm down in the emergency room. This mother sees me in the triage area, tells the receptionist, could you get her? And they called me Betty Boop. It was an easy name for all of everybody to remember. Betty Boop, right? Pulled me out and she looked at me and I saw Manuel Louis in the wheelchair next to him. And I looked and I said, are you Manuel? And the mother looked at me and she said, how did you know that? And she pulled out her keychain and there was a picture 14 years later of me holding Manuel Louis at his bedside. And she wanted to hug me and thank me for giving her encouragement and knowing that the kid would be fine. And he goes to regular school. He just had his 8th grade prom. He had a date and he's living life to the fullest. And she sat and cried and just hugged me. So that little 5 minutes of time that nurses can do can change a lifetime for anybody. So yes, you need to take your folic acid before you get pregnant. All right, let's go into some muscular dystrophies. This is the worst. Werding-Hoffmann, floppy infant syndrome. So usually we pick an infant up, they lift their head up. So that picture there looks like a 6 or 8 month old child. His head's still hanging down, no muscles, right? They sort of look like a frog, the way that they sit. These children, you usually will find out because they're not lifting their head and whatnot, because initially nobody moves. They all look like floppy infants, right? But then they don't move at all. And they're usually die by age 2. And it's all about muscles. That's your diaphragm and your heart. Just stop. It's not a nice. Now, the most tested of every dystrophy on any exam in nursing is Duchenne muscular dystrophy. Duchenne muscular dystrophy is the most severe and most common. It's boys ages 3 to 5 when we figure it out. It is from mom. It's an X-linked inheritance. So mommy causes the baby boy to get Duchenne muscular dystrophy. So it says that we don't diagnose between 3 to 7 years. Now, this child will be slightly delayed, maybe starting to walk, and then all of a sudden starts to fall down a lot, progressively getting weaker and weaker and weaker. His thighs are going to be hypertrophic, thighs and maybe even his upper arms, hypertrophic, like super big, okay? These children are going to end up in wheelchairs. And usually, as a teenager, they're going to die from either respiratory or cardiac failure. Remember, it's muscular dystrophy. The diaphragm's a muscle, it stops working. The heart's a muscle, it stops working. This child requires aggressive physical, speech, and occupational therapy. These kids, very hard to diagnose. We're seeing this, starting to fall down. We see progressive muscle wasting. We're going to do something to test muscle strength. It's called an EMG or electromyography. And it could either be little patches like an EKG patch, or it could be little tiny needles like acupuncture sort of things. And they put them along a nerve root. And the little machine that's right there will just put in a little electrical shock. And you see how quickly the muscle reacts to it. Now, what they do is they test arms and legs and everything on these children. When they come back after this exam, they felt like they just ran a marathon. So let the parent know that they may come back hurting because they are exercising these muscles and they might need some acetaminophen or ibuprofen. Just be aware of that. As I said, this is a kid who's, we might see these hypertrophic, thighs and upper arms. We might see the lordosis, that's lower curvature of the spine. We might start to see that. But you start to see they're waddling, falling down. Do you remember what Gower sign is? This is what I do every time I get up off the floor. I walk up my legs, right? You just don't stand up. I've got to help myself up. I walk up my legs. That's Gower sign. And this is things you would see with muscular dystrophy. Again, no cure. We just need to keep those muscles moving as long as we possibly can, and genetic counseling for that family in case they do want another child because they have a boy. It's probably going to have Duchenne. Now, Guillain-Barré syndrome. I actually had a nursing supervisor, she was 20 something at the time, who had an upper respiratory infection within a month of onset. And all of a sudden, she was shuffling and she was falling down and admitted to the hospital. And then it was admitted with Guillain-Barré. It's the only reason why I know this syndrome so well. This is a syndrome. It's usually in your kids 4 to 10, and it starts out from the feet and then it works up to the lungs. It is the nerves stop working. Okay. And it's ascending the way the symptoms go, which means feet working up to the diaphragm. Diaphragm stops working and they stop breathing. So, what symptoms would we see all along that would alert us maybe this is what's going on? Well, we're going to see that falling down, maybe the numbness, maybe we start seeing incontinence, constipation, because remember the nerves are getting up to the urine, to the bladder now, right? And then maybe feeling, loss of reflexes. That's what we start to see, and that will give us the clue. Again, these children, if we are suspecting Guillain-Barré, must be monitored minimum of an O2 stat monitor, making sure that they're oxygenating. How do we treat Guillain-Barré? Well, IVIG is always boost your own immune system, the intravenous immunoglobulins. Steroids are given, and maybe there's something, a viral component in the blood, and we can pull it off in what we call plasmapheresis or apheresis. It's just pull some stuff off they don't like there. And again, during this whole thing, it's maintaining your respiratory status. They cannot breathe at all. So, how do you know when this treatment is starting to work? Well, they can't breathe, there's no muscle. All of a sudden, you're going to see this child trying to breathe over the ventilator, taking extra breaths, because the ventilator will be set, let's say, at 20 breaths per minute. All of a sudden, they're breathing 30 a minute. So we know they're starting to breathe. And again, that numbness is going to go down. So it came from the feet up, it goes from the diaphragm down now. Tetanus. Step on a dirty nail, right? It's also called lockjaw. And why is it called lockjaw? Everything here gets swollen and shuts up and you stop breathing. And it's painful. So, because everything's swollen, now the lungs can't breathe, the laryngospasm, everything's all intense, and you need to breathe this child. So, we've got to, this is probably one of your sickest kids you'll see in an ICU, because they have this disease that is smothering their lungs and not allowing them to breathe, and it's all tense. So, what they're going to do is put them on a ventilator. We're going to paralyze, sedate them, and we're going to be giving tetanus vaccines in order to get these children out of this tetanus thing. Now, if we get them out to day 4, they usually will make it. So you can imagine 4 days of real hard working. So how do we prevent tetanus? Well, as soon as we get a cut anywhere, we should wash it with soap and water, wherever the thing is. Again, even as we're treating this child for, breathing from tetanus problems, we're still going to be cleaning the wound wherever it was, soap and water, and giving that tetanus immunoglobulin. Sometimes we even do it around the wound also. So again, all this tenseness, this is airway being shut off. This child is going to be made paralyzed, sedated. We're going to be giving that immunoglobulin therapy to that, cleaning the wound, and because of this tense muscle spasms and it hurts, we're going to paralyze this child chemically with medications. One of them's called Pavulon. So the muscles relax and let that ventilator work. Botulism. Have any of you had a child and grandma says give a little bit of honey when they're constipated or a little bit of Karo syrup? There are some cultures that do that. Problem is, it can have botulism in it. It's honey or light or dark corn syrup. Not recommended for children under the age of 1 or 2. I mean, you have to be older to drink this stuff. Very similar sort of things with botulism, where weakness, dizziness, and again, speech, and again, this is all getting swollen, and now you're even having a hard time talking. Again, we're going to be giving the IV botulism immunoglobulins. We're going to take care of respiratory, whatever it needs, and always nutrition, 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 and we're going to continue until this child's out of it. Okay, and spinal cord injuries. Spinal cord injuries can happen for many reasons. I mean, at birth, you can pull them and you can snap a neck. If you ever think about how a baby comes out, it's like you wonder why more necks aren't snapped, right? By the way that they come out. Motor vehicles will always be number one in injuries, right? And of course, sports. The other one is hyperflexion extension. That's like when you get in a car wreck and your head goes forward and back. That's what that's talking about. So, what's your job for a spinal cord injury? Let me give you the scenario. 16-year-old boy goes sliding into third base. His knee hit his head hit the defender knee. The crowd heard a crack. He laid on the ground and his right leg went numb. Spinal cord injury. This is a case where I was the primary on. And I had to make sure that this 16-year-old was taken care of properly. So rescue was called. He was helicoptered to me. He had on, of course, a collar, brought in to my emergency room. What is my goal? Primary nurse, I'm in charge. Number one, I'm in charge of keeping that neck stable. He already had a right foot that was numb, his leg, and the left foot was tingling. He had an angulated C5, C6 fracture. I mean, it's supposed to be straight down. It was like this. So we brought him to MRI, which we never do in an emergency room, but we had to because of the severity of it. I'm the one who kept charge of his neck. Nobody would touch it without me. And we got him up to the PDICU. We got tongues put in him, put him on a cooling blanket to keep the swelling down, gave him good sedation. And the next day he went to the OR. The end of the story. 2 weeks later, I said, let me go check on whatever his name was. Go up to his room. And the next day he was going to go into rehab. His left leg was completely fine. And he only had minimal tingling on his right foot. Continuation of story. 1 year later, he came back in to see me on a weekend, and he was jumping up and down and telling me he was absolutely perfect and gave me a hug and told me thank you for holding his hand and keeping him calm during everything that was going on. So again, I kept him calm. I kept him stress-free. He knew what was going on. We got everything done, and this child went through it, and he came out flying colors. It could have gone the opposite way. He could have been paralyzed. So, what is the progressive infantile spinal muscular atrophy, which is floppy infant? It's called Werding-Hoffman's. So, you had a lot of stories today. Do you like the stories? I hope the stories help you remember things, giving you that. All right, let me get you into the cahoots. 1 second. Where'd you go? There you go. So as I said, I'll be grading these things starting. I've done some already. I'm going to do some more. I should have them all done by Wednesday. Remember, if you're seeing me write a little comment and you were turned in on time, I'm going to let you do one time, get it turned into me. You can one time turn it back. Where did it go? What's the win today? Shiona, you're going to win today, aren't you? I think so. Ashton, you look like you were right there with me too. So remember, this week is all of your reviews. Mine's on Wednesday at 2 o'clock. Yes, it'll be posted by 3:30. You know how quick I get that up. Anybody wants to come to that review, please. Anybody who wants to see me before the exam. Exam 3 can be tricky, especially you guys miss GIGU. Anybody who needs to see me to go over concepts, please send me a message. Thursdays and Fridays are great for me in the afternoon. Okay. So just let me know, and I would love to help you get through this course. No reason to do it again. See me. Week 9. 3 more weeks, we're done. Woof. What is the priority for a nurse to assess following a cast application? So remember 6 P's, right? Very important concept. Pain, pulselessness, movement, paresthesia, pressure. Those things are very important that we check, and we also teach our uh, children and our parents. Another multi. Patient teaching for a child with a fractured bone that has had a new cast applied. It's part of your discussion question. So that cool hair dryer works really well with the itching. Never powder or lotion. It'll build up in there and it be, create an area where bacteria and whatnot can form. And nothing inside it and cannot get it wet. What should the nurse monitor after a soft tissue injury? Bruising, ecchymotic area. What are you concerned about? I mean, is it tiny? Is it superficial? Or is it looks like it can be a really big ecchymotic area? Again, always be, going for that neurovascular sign, looking at the colors of the toes or the fingers and, checking them. It's something that should always be done with any injury. A fracture that penetrates the skin is called. So when the skin is open, it's called a compound. Remember, our concern is now the bone is up into the air. We're worried about osteomyelitis. A multi. Ryan's traction. Remember, this is for DDH, developmental hip dysplasia. This could be a toddler under 30 pounds. You have to be in order to use this traction. What else do we know about it? First, we want to hang those weights freely, but the hip should be up a little bit, and it is for that DDH. Very good. Always, always checking for skin breakdown because this kids move and it could cause rubbing. What is the priority nursing care of a child with a compound fracture? You have a child who's got a compound fracture. What's the compound fracture? That means the bone is sticking out. What do you do for a bone sticking out fracture? Priority. IV antibiotics, always, always, always priority, okay? So, yes, we're going to check neurovascular signs, but the nursing care that we need to make sure that we start as soon as possible is the IV antibiotics. What is priority nursing care for a child who fell off a second floor balcony? You know, believe it or not, in my career, I had 3 children, like age 2-ish, fall off a second floor balcony. They went out to the balcony, got on a chair and a table, and they fell off. And they were brought in. What is our concern about these sort of injuries? It's all about immobilizing the spine. You don't know. They could come in moving everything and no complaints, but they could move a weird way and they could be totally paralyzed. So again, your priority on anything that could affect the spine is that strict immobilization. Principles of managing soft tissue injury include it's called RICE, rest, ice, compress, and elevate. Yes. An epiphyseal plate fracture in children may do what? So epiphyseal plate, the other name for it is a growth plate, and it'll affect the growth of bones and it can make bones crooked, and we don't want that. Those that child will have an open reduction internal fixation. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So neurovascular impairment, that means there's no blood flow going down there. So it's an absent peripheral pulse. Absolutely. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? What's your job? What do you need to do? What is your nursing care? You have traction going on. Remember, you never, ever, ever remove them. You don't change the weight on these tractions unless it's ordered by a physician. Usually they're not. Always document the weight and that weights are hanging freely, and you document that also. When caring for a 9-year-old buck's traction, what action by the nurse is correct? Again, this is just capillary refill checking it. We're not going to let kids sit on the bed because that could, disrupt, the buttocks and the jostlet that hurt the leg. No, we don't want to do that. They don't need to put that bed up and down. In fact, usually we turn that off and we never take the weights off. We want to keep that bone, so that there's no muscle spasms. What position do you put the legs of an infant with hip dysplasia? It's called abduction, and that makes that hip go back into the socket. Remember, the quicker we put it in, the better they are. What statement by parents indicate more teaching is needed regarding their 2-month-old with club foot? So that was a really interesting picture of club feet. I mean, that one's quite severe, but it doesn't mean that we can't just do this with that serial casting, right? And remember, serial casting is once a week. So you're not gonna wait for a month for a new cast. You start it as soon as you possibly can. It's probably going to need follow-up care because we don't know if the feet, et cetera, are going to stay the way they should. So they might need special shoes. And again, every week we're changing it because that's how quick they mold at that age. Neonates heal very quick. Multi. Osteogenesis imperfecta. You know, one of the things with osteogenesis imperfecta, I've actually seen some documentaries where some parents were almost arrested and accused of child abuse because they didn't know it was osteogenesis imperfecta. They saw a kid with all of these fractures. What would you think, right? Again, you'll see long bones crooked. It's called a brittle bone disease. And we're not going to do anything aggressive on this child. We're not doing physical therapy because if we could do physical therapy, you're just going to break another bone. What is pathologic cause of leg calf girth disease? Can you see that right hip? Can you see the head of the femur, what it looks like? That's called it's called necrosis. Should be a nice, delineated edge, not fuzzy like that. When you see fuzzy, that's an infection. It's an ischemic aseptic necrosis, which means there's no blood, there's no infection, and the tissue, the femoral head is dying. And our goal is to protect that head. How do we protect it? Bed rest, maybe buck traction, good nutrition. All right. Buck traction is great for that one at home. Kyphosis, what's that? It's called humpback. That's the top of the spine. Very good. Multi. Which assessment indicates an infant has developmental dysplasia of the hip? We'll have those asymmetrical leg folds, the positive ortolani. Everybody has a Babinski, whether they're children or they're adults. It doesn't indicate hip dysplasia, okay? But the leg folds and ortolani, yes, very good. Lordosis is described as what? Remember, this is the one that Duchenne muscular dystrophy those children usually have. And they usually are a little bit overweight, the Duchenne. So it's the inward curve of the lumbar spine. You sort of walk backwards, leaning backwards. Scoliosis is scoliosis. Think of S, scoliosis, S-shaped curvature of the spine. What do you need to know about scoliosis? Adolescents with scoliosis that have up to a 45 degree curvature of the spine would need to do what? What is treatment? Up to 45%. How do we treat it? And remember, up to about 45 is only a brace, physical therapy. After that, it's surgery, okay? How do we take care of it? Physical therapy, brace 23 hours a day. A multi. Teaching for child with scoliosis with less than 40 degrees of curvature. What are you going to teach the child? Remember, these are usually adolescents. So wear it 23 hours a day with a cotton shirt. Absolutely. Physical therapy for sure. And they don't want you to put lotion and stuff underneath there because it creates where an area where it can cause more irritation. And that's not put it under the brace. Now, putting lotion on your body, putting the cotton shirt and then on top, but not just to put it underneath the brace. No, a multi. A Pavlik harness. What is that for? So Pavlik harness is what we use for the developmental dysplasia of the hips. We are going to hold those hips in abduction so it can pull those hips back into where it needs. You're going to check the skin always, and we'll massage underneath those braces just to make sure we keep the skin, very, very healthy. What is osteomyelitis? So osteomyelitis is osteo is bone and itis is an inflammation or infection. So it's a bone from infection. Remember, it's usually staph. Goals for juvenile idiopathic arthritis include, remember, this is an inflammation of the joints. The body's attacking its own joints. So what is our goal? We want number one. We want to reduce the pain and the swelling for sure. Absolutely. A multi. What might you anticipate for a child diagnosed with JIA? What would they be showing you? As in what assessment things? Remember, JIA is the body attacking the joints, right? So what do you see? Well, we wake up in the morning, we're stiff, we're hard walking, we could be falling over. We're going to have joints that are swollen and disfigured. And then there's something called uveitis, where the eyes, that the iris gets infected, and we need to do at least yearly eye checks on these children. Facial rash is lupus. It's not JIA. What is cerebral palsy? So remember, cerebral palsy affects body movements, muscle coordination, and it depends on the severity of cerebral palsy. A multi. What are signs and symptoms of spastic cerebral palsy? This is my little Jonathan. So it is poor posture, hypertonicity, poor fine motor skills, poor gross motor skills, poor balance. This is all the above. A multi. When feeding a child with cerebral palsy, what's important to remember? So remember, cerebral palsy, we got these muscles are hypertonic, they're spastic. What are we concerned with feeding? Well, we've got jaw, we got muscles. Are they working? Right? These are things. And always remember, as I said, cerebral palsy, always consider safety. So have the head of that bed elevated to prevent aspiration. You need to give this child time in order to chew it and to swallow it. Sometimes you have to give them a little support. Children that have trouble swallowing will be getting thickened liquids, not thin ones, okay? And just because they have cerebral palsy doesn't mean that everyone needs a gastrostomy tube. Yes, some do, but not all of them. A myelomeningocele, that's that folic acid thing. Neural tube deficit. So your meninges and your spinal cord are pulled from the bottom, rips the nerves, and it comes out of the lower back. Treatment of this thing? Well, sterile. Keep the integrity of the skin around it, right? And then monitor those lower legs. Is there deficit? Checking urine, checking stool on that. Very important because we have really pulled those nerves there. And again, keeping that clean, the skin clean so that we can close it as soon as we can to prevent infection. A multi can help a child with lupus erythematosus prevent exasperations. What did I tell you the biggest thing about lupus is? So sunscreen, absolutely. And then with any sort of immunosuppressed, absolutely lupus, JIA, anything prophylactic before any dental extractions, etc., has to be done. Just prophylactically, because remember, the body does not deal with infections like a normal child would. Infants with a myelomeningocele demonstrate what? And I could say of the lower extremities. And that is motor and sensory. Some children do have good movement, some had none, some have minimal, and some feel and some don't at all. Again, there's all different. Depends on how much is pulled, how much was out, where exactly did it come out. There's so many variables there. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? Knowing that the child is a myelomeningocele, what are things that you're going to be monitoring? Basically, myelomeningocele. I've got the meninges spinal cord on the outside. I've got decreased sensation in my lower extremities. I need to be concerned about number one, urinary retention. The rest, yes, foot drop, skin drown, contractions, yes, but my one thing that's real close, urinary retention, because you can actually burst that bladder because they're just not going to urinate. Sometimes you can just put a little bit of pressure right above their bladder and they'll urinate, but sometimes you have to do the catheter. A key feature of Duchenne muscular dystrophy is, I thought that was a great picture that showed you basically everything that Duchenne might have. Weak muscles, the knees bending wrong, the sway back, the way they walk, the big belly, etc., etc. So remember, Duchenne muscular dystrophy, muscles dystrophy, which means the muscles are stopping working. So it's a progressive muscle wasting. Yes. What is one of the procedures that a child with possible Duchenne's may need to diagnose the condition? What's the name of that? Remember, they're going to act like they just went through a marathon. They really stimulate those muscles. And it's called an EMG, electromyography. Remember, this is a child that you should offer at least acetaminophen to when they come back. They will hurt. How is Duchenne muscular dystrophy inherited? Again, this is part of why they're going to need some sort of genetic counseling if they want to have another child, right? We have to know, how is it inherited? Where did it come from? It comes from mom. X-linked recessive. It makes mom feels guilty. It's one of those. In caring for a patient with Guillain-Barré, the priority concern is, well, we know Guillain-Barré is an ascending decrease that the nerves, neuritis stop working. So our biggest concern is as it goes upwards, it hits the diaphragm, the phrenic nerve, and you stop breathing. Big thing is keeping the airway open. Minimum, this child needs to be on an O2 sat monitor, monitoring them closely. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? We talked about a lot of stiffness and whatnot on awaking. No, it has nothing to do with that. Guillain-Barré is all of a sudden the nerves in the feet, stops working, and all of a sudden they're shuffling and paresthesia, and it goes upwards. Okay, so that's called ascending from feet to the phrenic nerve. Multi treatment for Guillain-Barré include. Remember, Guillain-Barré was caused by an upper respiratory, they say, maybe a month before, around there. Guillain-Barré is that neuritis where the nerves just stop working. It is due to a virus. It's not due to bacteria. So no antibiotics. Treatment, IVIG, respiratory, and maybe steroids, okay? No antibiotics. And then having them on a ventilator and good respiratory care. What type of cerebral palsy causes hypertonicity and poor fine motor skills? And it's called spastic. Simple as that. Very good. What priority action should a nurse take to a patient with suspected spinal cord injury? Remember, when you have any suspect of a spinal cord injury, if you're the nurse in charge of that patient, your responsibility is to keep that immobilized. And I could tell you at least 10 people are in the MRI room with me. And I'm like, I'm in charge. It's my head. Everybody quiet. You go there, you go there, you go there. When I say it, we're going to do this. 1, 2, 3, now. I mean, it was extremely clear what to do. That is your priority. Mobilize it. Keep it mobilized. You should get a tetanus shot. How many years? This has changed 3 times, 4 times that I knew of. It used to be every 2 years, many years ago. Now it's every 10 years. It's every 10 years now. And they're also doing diphtheria with tetanus shots now. What is a symptom of tetanus? stepped on her nail, and it is lockjaw. Remember, everything gets swollen, your airway goes to bronchospasm, you don't breathe. It's all about decreasing the muscle spasm with, giving them a muscle relaxant like Avalon, which is completely stops you from moving. And then it's the IVI tetanus and getting the child 4 days later, if they're still alive, probably they're going to make it. And last question. Most common cause of spinal cord injuries are? And it's motor vehicles. You always pick that one. We're talking about any injuries, motor vehicles, driving, or sports. Very good. Okay, let's see how we did today. Ashley, good job, Ashley. Number two, Ashton. Good job, Ashton. Number one, you did it. Good job. I called it. Whoop, whoop, choop, choop. James, there you go. Good job, guys. I'm glad that you enjoy doing it and that you do well on them. Remember, it's week 9. We're going to be doing our reviews this week. Know that I'll be doing mine on Wednesday at 2 in case, you want to come to that. They will be posted. You know me, I get them up pretty quickly. Does anybody try to open up the PowerPoint or anything from the exam review? And if you were able to, you were, okay, great. Just making sure, because sometimes it does, sometimes it doesn't. Again, I'm going to post it again anyway, but just to be sure. All right, guys, I'll be doing your assessments. As I get them done, you see a perfect 100, you do have the ability to do it one more time and send it back. Let me know you've done that, okay? Have a great day, everybody. Thank you.